So I'm Dr. Showkat. I'm based in Hammersmith Hospital at Imperial College London. I renamed this talk to Dr. Mahmood Manwar talk on aortic regurgitation and the unexplained. Dr. Manwar was a cardiologist in Bangladesh, graduated from same medical college. I studied medicine in Bangladesh. He was working as an assistant professor of National Institute of Cardiovascular Disease, Dhaka, Bangladesh. Treated many COVID-19 patients admitted in disease before COVID-19 coronavirus took his life on 12th June, just a few days ago. I trust Dr. Manwar, you are resting in Jannah, in heaven. I'm dedicated my talk to Dr. Mahmood Manwar. So I do not have any conflicted interest with this talk. So, and if you see my first slide, every day we are getting message and information about COVID-19 death. And this is, I have taken from the Washington Post, published in April 2020. What you see here, coronavirus is killing more than other causes of disease in United States is from 6th April to 12th April. But heart disease is still the #1 causes of death in the United States. So, and the burden of heart valve disease, vast portion of our patient, when we assess patient in the echo lab, either they're coming with some kind of queries like patient have got palpitation, patient might have got some kind of shortness of breath, or patient might have other problem, maybe query for ischemic heart disease. But whenever we assess valve, one of the things we see that there is some kind of valve problem we see while we are assessing patient. So if you look at my left slide, if you see as people go older and prevalence is increasing and all kind of valve diseases. So this is a very, very interesting slide I have taken from, it was published back in 2003 European Heart Journal. And it's not a huge number of patients, but still it's quite significant number of patients. The 5,001 patient and one of the European study, you can see the reference in the bottom. And among those patients, 72% patients have got native valve disease. And if you see the distribution of this valve disease, aortic valve is actually contributing the bigger number compared with the mitral valve and other valves. Aortic valve is contributing almost nearly very close to 50%. And if you look at that number, among aortic valve problem, aortic stenosis is more commoner than aortic regurgitation. Around 10% patient presented with aortic regurgitation. So when we talk about aortic regurgitation, and this is a valve you need to think about first thing whenever you see any valve in a clinic, when you start your echo, it's query of aortic regurgitation. You need to think about, read the background history, and you need to think about what might be cause. And then you will start assessing your patient. So for very simple understanding of this problem, so that what I personally prefer, that there are two big reasons for aortic. If I give it two big heading for aortic regurgitation, either it could be a problem with the valvular disease, or it could be a problem with the aortic root. So one, valve itself, this is, I would say, is the primary disease. Actually, valve making heart sick. And when the other cause is aortic root dilatation, it's not problem directly with the valve, but problem with the aorta causing valve sick. So this is, I would say, secondary. So among the primary valvular disease, you see the most of them are degenerative. And like also congenital, that bicuspid valve. I think is one of the commonest cause of in the Europe, aortic regurgitation. and also degenerative and rheumatic cause for aortic regurgitation in Europe is not very common. And whether you see like part of Southeast Asia, you'll see lots of rheumatic fever, either not only one valve. Normally, the rheumatic valve involve multiple valves. So other causes of valvular dilation is like endocarditis. So endocarditis is rather of like a chronic aortic regurgitation. It may present as acute aortic regurgitation. I'll talk to more details of that. And on the other hand, in aortic root, this what I call that the problem somewhere else in the heart is causing aortic valve sick. So aneurysm and aortic root dilatation is that very common. And you see dissection, and you see hypertension, the more funds. And I think hypertension is like one of the commonest cause where you see long-standing hypertension. A patient presenting with mama, you find that like problem has got some kind of valve problem. So if you look at the bottom images, like this is one tricuspid aortic valve with calcified tricuspid aortic valve. On this one, what you see here is like bicuspid aortic valve with calcification. On this one, you see in the aortic valve, there is a characteristics for rheumatic commissural fusion. And if you this one come into these images here, you can see hole here. This is kind of actually infection damaged valve. It is because of infective endocarditis. We'll talk more details about that, how to assess infective endocarditis. And on the right, if you see, this is like typical muffin. It's hourglass shaped aorta. So now talk about the guidelines. I think probably we, wherever we practice, the guidelines guides you, but guideline is not the end of the world. It's not Bible or it's not Quran. So you need to apply guideline where possible. So, and if you read, I think many of you have read the latest guideline, European Society of Cardiology guideline. What is new in that guideline? So it was suggested that use of transesophageal echocardiography to evaluate the results of surgical and percutaneous intervention. I've got one slide to show why it is so important to do transesophageal echo. Then MRI is considered useful when echocardiographic studies are not optimal, and also suggested for multi-detector CT with ECG synchronization when surgery is proposed due to its better temporal resolution. CT has got better temporal resolution than echo. So now, what is the questionable aspects of that guideline, in which European guideline published in 2017? Criteria for aortic valve repair or replace are poorly defined. Although they have got suggestion, but for the, especially for repairing aortic valve is not much. And comprehension of the treatment algorithm is hampered by its initiation with significant dilatation of aorta, ignoring regurgitation severity. So, and now if we move to American Society of Echo guidelines, I think most of you have read both these guidelines. So it was published in April 2017. And you can see the reference where you can find and read these guidelines. And like, what is new on that guideline? So, and again, it is also published in the same year, 2017, August. It was published, European guideline, but American guideline was published in April 2017. So they are actually giving the same kind of message. So both emphasis identification of mechanism of regurgitation, right? Why mechanism is coming into more and more importance. And I also mentioned about 2D, 3D transthoracic echo and integrative approach and algorithm to assess severity. And also it is mentioned when is transesophageal echo is needed when you assess aortic regurgitation. So also they put emphasis of cardiac magnetic resonance. What is the British guideline? We need to, and British is going through the Brexit. Is like we have started Brexit negotiation process. I think we have already out of Brexit, and it will be fully functional at the end of this year. So currently, Britain doesn't have any kind of other guideline. So we need to wait to see British guideline. I think probably next year. So. And now we look into European Society of Cardiology guideline, management of aortic regurgitation. You might ask me, Monjur, why you have given this slide before you are actually talking about anything in echo? The reason I put this slide before like anything about echo, because this guideline will help you a little bit to think about that when you actually assess valve, what are the important things you need to address. So you can, do you know where to get this kind of guideline? If you go to European Society of Cardiology guideline, you can easily download that. You can read that. That's very useful. And also that is they have simplified very well. So it is actually like, it's very useful. So when you follow this guideline. So what that guideline is telling, significant enlargement of ascending aorta, if it is then class 1 indication for surgery. So it is valve itself is problem, but aorta, ascending aorta is significantly enlarged. So it is class 1 indication for surgery. And now look at that. If not significant aortic regurgitation, then you need to look for symptoms. If you see symptoms, and like, then what you need to do, again, it is symptomatic, again, it's a class 1 indication for surgery. If there is no symptom, these are the few parameters. Whenever you assess valve, you need to look at these few parameters. These are the subclinical points, or subclinical few echo parameters that actually guide your decision when you refer this patient to the surgeon to replace valve. When LV ejection fraction is 50% or less than that, or LV end diastolic diameter is more than 70 millimeter, or left ventricular end systolic diameter is more than 50 millimeter, or body surface area is more than 25 centimeter per meter square. And if you see all these points I mentioned, subclinical LV dysfunction, then again it's a class 1 indication for surgery. So if not, and patient has no symptom, then you need to follow for maybe 6 months, or some follow for 1 month. It is actually, you need to decide according to your patient how good or how unwell your patient is. So it is so, again, I'm just summing up this slide again. So when you see significant enlargement of ascending aorta, as 1 indication, no enlargement aorta is a problem with the valve, and symptoms, again, class 1 indication, no symptoms but subclinical LV dysfunction, then is a class 1 indication for valvular replacement, indication for surgery. And class 1 indication means there is no dispute. If you do not refer to surgeon, and if the patient do not go for valve replacement, that can actually dangerous patients. So now I'm moving into an echo. So when actually you are assessing aortic valve for aortic regurgitation, or assessing valve, what are the things you should look for, or anyone should look for? And like I mentioned already, you try to find out the etiology. Is it because of the problem with the valve, or it is because of the problem with the aorta? And if you look at the valve, then you look at how many cuffs. Is it a bicuspid valve, or is it a tricuspid valve? Is it thickened? Is there a problem with restriction with the valve movement? Is, if you see doming of the valve, you can see in rheumatic valve. you see prolapse, if you see calcification. These are the few valve morphology. When you actually assess valve, you need to look at a few things. And before actually you assess the Doppler and all other studies like jet direction and origin. When actually assess jet direction and origin, you need to see whether that jet is central, whether it is eccentric, or is there any problem with the commissural, and is there any ascending aorta dimension. So, and when you come to assessing severity, that is a very integrative approach, and that is not very easy. And so you need to measure Veena contractor, you need to measure pressure half time, you need to measure flow reversal arch, and then LV dimension, obviously, and body surface area, and chronic severe AR, LV almost always dilated. One thing I forgot to mention about that, whenever you assess any valve, do not forget to put down patient's heart rate, blood pressure. Actually, when you're actually assessing aortic regurg for regurgitation, it's very crucial to put down a blood pressure of the patient, because somebody with wide pulse pressure, say systolic blood pressure is 130 and diastolic blood pressure is 30, so it's a huge big pulse pressure. So it's again telling you that this patient has got like severe aortic regurgitation without actually doing any kind of echo. So blood pressure is really, really important whenever you assess not only aortic valve, any kind of valve. So now look at the surgery. When surgery is recommended, because I mentioned at the very beginning of my talk today, when left ventricular diastolic diameter is 70 millimeter, and then left ventricular that was systolic is more than 50 millimeter, then ejection fraction is less than 50%. Now mechanism you need to, when actually assess valve, you need to assess the mechanism of aortic regurgitation. There are 3 different types of mechanism. I don't know how many of you actually assessing this mechanism while you actually aortic valve for aortic regurgitation. And it actually depends, like echocardiographer, the cardiologist, they assess for mechanism. When there is a skilled surgeon, they can repair valve instead of replacement. So that actually is a very skilled surgeon if you think about referring patient for assessing mechanism and do these assessment. So there are 3 types of mechanism, and type 1, what you can see, normal cusp motion and with aortic dilatation or cusp perforation. So these are the normal. So cusp is normal. There is no problem that the aortic dilatation that's actually causing a valve to leak. And then type 2 is a cusp prolapse. You can see cusp is prolapsing. So this is still this valve can move well. And there is type 3, cusp restriction, where cusp aortic valve cannot move nicely, and there is a problem with movement of aortic valve cusp. It's a restriction. So which valves are repairable, which valves are not repairable? Type 1 and type 2, if you have got a good surgeon, very good cardiac surgeon who has potential skills for repairing valve, so and your patient is young, so these type 1 and type 2, this is a repairable valve, so you can spare valve and you can still deal with aortic problem. And type 3, because it's restriction of movement of aortic valve cups, so that valve, even the patient is young and the surgeon has got potential skill, then you cannot actually think about repairing this valve. This is another slide of like aortic root dilatation. I mentioned like going to like this another causes of like at the very beginning I mentioned, even your valve is dilated normal, but aortic root is dilated normally is 5 centimeter or more, then you need to refer this for assessment. So let's go on to echo. So So this is, can you see this echo valve? This is one of our patients. Like whenever we assess any kind of valve, we actually start with parasternal long axis view. This is a parasternal long axis view. This is a left atrium. This is a mitral valve. This is LV. This is a aortic valve, and this is ascending aorta. This is right ventricle. So you can clearly see that this is a gray image. I didn't put any color yet. So you shouldn't start putting color when you start assessing valve, and you need to do the gray image. What you can see, that's very like eyeball assessment. This LV doesn't look normal. It looks like a bit dilated. Actually, and this patient was a problem with, he has got high blood pressure, is hypertensive, and he was 40 years old and he has got murmur. So once we saw that, and that we can see the dilated LV, then we assess valve, and then we put color and everything. We found this is a church, and like we assess. I have got some few more video clips that I can show you what to look when you actually assess the Doppler and you assess that. So first thing, what you start with, you need to start any kind of aortic valve replacement. You need to do 2D measurement. So if you look at the slides I'm talking, it might confuse you a little bit, but look at this. If you read your guideline, or you can remember from the guideline what you have read, when you actually measure aorta, in the guideline they said leading edge to leading edge. So, and what I put internal edge to internal edge. I'll explain it why. So, and so you need to valve for like, when you actually measure aortic annulus, you need to measure annulus during mid-systole. So this is very crucial. So if you measure annulus diameter during the diastole, you will get a wrong measurement. So, and like we talk about lots of 3D for so many things, but still the basic transthoracic echo measurements are very important for making your decision. So, and now look at that, and then you need to do it. Like sinus level, and you need to do sinotubular junction, and you need to assess in the ascending aorta. So you need to do in this level, and in mid-systole, all of that at the sinus level and the sinotubular junction, and in the ascending aorta, you need to do during diastole. So if you if you measure all this diameter in one cycle, then actually you are doing something wrong. You will not get the proper. So look at this one. So I think probably you can remember leading edge to leading edge. So it's not internal edge to internal edge. And it is still in the European Society of Cardiology guideline, which was published. I showed in back. And also that is also mentioned in the American Society of Echocardiography. The problem with this, and why I'm not quite agreeing with this guideline, if you see, like these days we need to compare or validate our data with MRI or CMR or CT scan. What happened, like especially for the volume, measurement of volume, CMR is much better than 3D, 2D echo, definitely 3D echo, and the CMR actually best for measuring volume. So CMR and CT scan, they have used internal edge to internal edge. So if you are comparing data with CMR, so please make sure you assess your valve when you measure valve. You do internal edge to internal edge. So it will actually, I think probably maybe in the future guideline they will think about that, because in current practice, CMR is actually taking a big role when we assess aortic valve for replacement or repair. So I'm showing you another that this is in the frozen slide. This is one of our patients. That gentleman, young gentleman, he was 35 years old and he had got hypertension. So if you look at that, so and whenever you see mentioned hypertension and the patient had murmur, so we tried to find out what is actually causing his murmur. So this was aortic valve, and you can see that aorta is dilated. So especially with patient with bicuspid aortic valve, when actually you assess any bicuspid aortic valve, one of the problem is bicuspid aortic valve can be associated with aortic dissection. So you need to, this is a very technical point. So you need to go a rib space higher to see, look for the aorta, ascending aorta. So, and this is whenever you actually see any kind of bicuspid aortic valve, you need to think about that. Is this causing that? And also, like, if you assess any young patient with hypertension or bicuspid aortic valve, you need to ask about, is there anything else in addition to this aortic dissection? Is there anything else could associate with? So this is one of the things you can see, the squartation of aorta. So that is also associated with bicuspid aortic valve. So you need to do two measurements. You need to know all these normal levels and abnormal levels. So this is about 2D measurement, what actually you actually, with regards to dimension, like know what's the diameter of the LV and how the valves look like. Once you get this basic information from your image, then you need to think about, is jet is fanning out or jet is eccentric? You have underestimated that. Is hollow diastolic flow descending aorta? I'll talk through this in details. And what is the volume and pressure loaded, or is it dilated left ventricular hypertrophy? So you need to also measure pressure half time. Is it less than 250 millimeters a second? What's the Veena contractor? Is it more than 6 millimeter or more than that? Some say 7, but if it is more than 6, so you need to, it's not a normal aortic valve. So what is the effective regurgitation orifice area? What is the regurgitation fraction? What is the RV volume? So these are the few points that will actually tell you whether the aortic valve regurgitation is mild, moderate, or severe. So Doppler is quite crucial when actually assessing aortic. And one of the, and like Doppler equation, I think probably you all have memorized this Doppler equation. And so what is actually Doppler does when you put probe in, and that's transducer actually goes into the, like moving to the red blood cell in a vessel, then transducer acts as both transmitter and then receiver. This is a very, very complicated Doppler equation. So like, we are not mathematician, or we are not physician. We need to make our life very easy when we clinical knowledge in, like, in can smartly assess aortic regard. So what is very important? So whenever you actually assess any kind of valve, it's not only aortic valve, it could be any kind of valve when you use Doppler. So what you can see, go back to your old college days when you did all this mathematics, you can remember that cos theta. So I think whether you can remember all these things, cos 90 degree is 0 and cos 0 is 1. So what is actually telling you, if you put probe and in the jet, like aligned to the jet of the regurgitation, his angle is 0, so actually you'll get the best information about that flow characteristics. So if your probe is 90 degree, so you're actually not seeing things. So try to be like, we ignore like until 20 degree. So if it is Doppler probe is less than 20 degree aligned with this flow, then actually you actually get a better assessment. So remember, cos 0 is 1. So you actually get, this is the best way. You actually going into the Doppler probe is actually heading in the same direction as the blood is flowing. So if it is probe is 90 degree, so you not see anything. So I'm not going very details of that physics of this talk. So now again coming on, like there are a few view and you actually can like see valves. So I think probably you all need these kind of things like parasternal long axis view, then apical window. Whenever you got, you try to apply and suprasternal window. Why it is very useful. I have got a slide about that, and I will mention then why it is also too when you actually assess value, you need to apply this technique as well. It's not very easy, but it is very useful. So this is something about Doppler when you actually see Doppler spacing. So outflow track normally you can see ventricular line. So this is some I have got slide for this regurgitation flow profile, how it looks like. I have got a slide for that. And regurgitation flow characteristics, you need to assess PISA, you need to do Veena contractor, you need to assess the jet area, whether it's eccentric and is central jet. So PISA, I think probably many of you apply PISA for assessing mitral valve. But if you have got set skills, it is also useful to apply PISA in assessing aortic regurgitation. So what actually happening in PISA? So blood is accelerating in a laminar patient towards a regurgitation orifice. So from multiple axial hemisphere of isovelocity, and this is how you actually start assessing PISA method for applying aortic regurg. So I think probably one of the things I have seen in like many countries, they like color M mode and color M mode echo. There are many people who likes M mode. So like the color mode, this is a very old slide. The reason I put this slide, color M mode for assessing aortic regurgitation severity. So if you see here, so this is the weight of the LVOT, left ventricular outflow tract, and this is like if it is less than a third regurgitation flow, that is not severe. If it is more than 2/3, then you can say it severe aortic regurgitation. But problem with this color mode, so and like you need to measure, when you measure that you need to put a probe 0.5 to 1 centimeter below the aortic annulus, and you with this method you might overestimate central jets for severity because it's fan out. So this I wouldn't recommend this current mode for assessing the severity of aortic regurgitation. Maybe you can try for like overall seeing how it looks like. And eccentric jet, you may underestimate severity of eccentric jet when you apply color M mode. So now looking to color flow. So this is a patient with, this is one of our patients. So you can actually see eccentric jet on this side. So and so you can see three components of Veena contractor, flow conversions, Veena contractor, and jet area. So when you actually do that, you need to set up Nyquist limit 50 to 60 centimeter. This is why you see Nyquist limit here to here. So you need to look that if Nyquist limit is not this range, then you need to solve this problem. Otherwise, you will assess and Veena contractor assessment would not be correct one. So if less than 3 millimeter is mild, if more than 6, I mentioned either 6 or 7, some say 7, some say 6. It doesn't matter. If it is more than 6 millimeter, and then it is severe. So but in multiple jet, you cannot actually apply this method. So now that is another way of actually assessing severity, and key here is you need to know who are actually you need to align your you need to put your probe at the area you need to align with. So when you look at this, it needs to be come up to 4 meters per second. Then probably if it is not if it is less than 4 meters per second, then you actually not actually capture aortic regurg flow good enough. So and pressure half time, I think probably many of you know, is actually what is actually it is that it take time taken for pressure across the aortic valve to fall by half. If it is more than 500, this is mild. If it is less than 200, 250, and this is severe. So the biggest problem with pressure half time, sometimes you see is compensated aortic regurgitation, and is sometimes the measurement between 250 to 500. So like how is LV is compensating that. So sometimes pressure half time between 250 to 500, sometimes it might be, yeah, it might be like the severe aortic regurgitation. So you just do not rely on one method. So you need to apply other methods as well. So this is for the normal, this is the chronic AR pressure half time. If you look at this one, so that stiff, come to the baseline very quick. So in that case, pressure half time is less than 250. You do not see this kind of changes in somebody with the chronic aortic regurgitation. You rather see this kind of changes in aortic regurgitation. And like, so whenever you assess somebody with aortic dissection, so you need to look at the pressure half time. The curve is stiff and touching that's baseline quicker. And also if you suspect of aortic regurgitation with aortic regurg with perforated valve, I mean infective endocarditis, you can, that kind of changes you can see with AR with infective or damaged valve. So, and this is not very easy to do. If you could do that, this is quite useful, like external, where you're putting your probe there and hollow diastolic flow velocity, and you will see the flow across the valve throughout the diastole. So if you see hollow diastolic with flow velocity more than 20 meters per second, you call it severe aortic regurgitation. It is not very easy to assess this hollow diastolic velocity, so it requires some practice. So, and hollow diastolic, look at this one. So this is again, you actually see hollow diastolic reversal abdominal aorta is very specific for severe aortic. These two things are not quite easy to assess aortic regurgitation, like supraesternal window. This is not a very like comfortable to see valves, and it takes really a lot of practice. So what you can see this one. So this is like another information about is actually when you're doing your PISA method, like what you seeing that RV volume that you see here is that PISA radius. And then you actually see that this that is the PISA radius, and this is you then see that was the effective regurgitation orifice area and RV volume. I mentioned if volume is more than 65 ml, then is a severe aortic regurgitation. And if effective regurgitation orifice area is more than 0.3 centimeters square, again, it's telling severe aortic regurgitation. Applying these kind of techniques is not very easy. You need to do a lot of practice for. So now coming to the point when you actually assess severe aortic regurgitation, you need to look at the qualitative information, excuse me. You need to categorize, is it mild, is it moderate, or is it severe? Look at aortic valve morphology, it is normal or abnormal, moderate normal or abnormal, or for severe, it is abnormal or flail, leaflet, or large coarctation defect. And color for ARZ width, that is in M mode, small in central jet, intermediate in moderate AR, and large in central, 2/3, more than 2/3. And continuous wave signal in ARZ, incomplete, faint, dense, and dense. So semi-quantitative, you mentioned as the Veena contracta is if it is less than 3 millimeter is mild. If it is more than 6 millimeter, then Veena contracta is severe aortic regurgitation. And pressure half time, if it is more than 500, then EU call is definitely is mild aortic regurgitation. If it is less than 200 and 200, then EU call is severe aortic regurgitation. I mentioned that in between 250 to 500, we call it intermediate path sometimes. You don't be very convinced if you have got suspicion of like patient might have severe aortic regurgitation, you may need to apply other methods. Okay, then quantitative. So you need to look effective regurgitation orifice area, then regurgitation volume. So you need to do that if it is less than 30 ml of regurgitation volume. So you can mind when regurgitation volume is more than 60 ml, you actually call it severe aortic regurgitation. So regarding getting that regurgitation volume, 2D is good, but you do not only rely on 2D echo. For getting better regurgitation volume, you need to, like if you have got facility doing 3D echo, for volume, 3D is better than 2D. And if you have got plan to do patient for a CMR before surgeon is actually placing valve or repairing valve, so it would be worth to assess regurgitation volume with MRI. Actually, CMR is best for assessing volume. So we have gone through like severe chronic mitral regurgitation. Now I've got a few slides about aortic regurgitation of. So we've got a patient of 45 years old gentleman presented with shortness of breath. You see presented, and you can see on ECG, you can see ST elevation in lead 2, 3, and also in AVF. So and patient shortness of breath. So this is a frozen image. What you can see clearly see that aortic root is dilated. We are looking into like LV, that's LV. Cavity look normal, but when we assess that aortic root was more than 5 centimeter. So, and like the color jet, you can see the eccentric jet, you can see eccentric jet here. So the patient in the cardiology that with our patient with shortness of breath. So we are trying to ask about few, and so we are thinking about that and the murmur. So we're asking that what this patient like, this pain radiated, any kind of pain radiates to us back. So whenever you see any patient with somebody with lead 2, 3, and AVF, there is change. You might think of it as well, right coronary arteries. And so right away you make decision of to inferior wall MI. This is in most of the cases you get inferior wall MI. This is very common. But whenever you see any kind of ECG is telling ST elevation lead 2, 3 in AVF, while that is right coronary arteries involved, but when this pain radiates towards back, so you need to be more critical. Is it just only inferior wall MI or something else? So then what you need to do, then you listen to murmur, and then you will find that early diastolic murmur, and you need to think about aortic dissection, because more than 90% of cases, aortic dissection actually involve right coronary sinus, and actually it ultimately involve right coronary artery. Eventually they are present with right ventricle, present with inferior MI. On ECG you see ST elevation is lead 2, 3, and AVF. So, and then that kind of is not a patient for you can patient referred to the cath lab and a cardiologist is actually putting stenting, that patient need to be like discussed with surgeons to take their opinions, and because that's a management is surgical, and you cannot try to do and putting a stent on somebody with like aortic dissection. You try to manage that heart attack with like putting a stent in. So like maybe you do not get every like all patients of like inferior wall MI with Louis T3 and AVF and aortic dissection, but you may have one maybe one patient have got this kind of things, but it's still more like watchful. So now acute aortic regurgitation. Commonest causes for acute aortic regurgitation is endocarditis, dissection, trauma, and post valve and TAVI. This you see. I don't know how many in our center. Is there one of the very renowned TAVI center in there. So one of the like complication may happen in aortic regurgitation. So what happened in acute aortic regurgitation? Sudden large regurgitation below on normal size LV. So now you do not see like cavities dilated, you see cavities normal size. But if you see normal new onset early diastolic murmur and cavity size, cavity size is normal, and because you need, why do you see that? Raised increase in diastolic left ventricular and diastolic pressure. So patient present with pulmonary edema, you get crackles, reduced myocardial perfusion pressure, ischemia, and hypertension. So, and what you need to do is not like transthoracic echo is not enough here. So you need to urgently arrange that TOE if you have got the people and set skills they can do. Look at a few cases. So this is one of our patients. So this patient presented with this 52-year-old gentleman with raised temperature and shortness of breath. So when we echoed him, that we used that Philips machine. Actually, you have got Philips. So what do you see that? And this is left atrium. This is mitral valve. This is left ventricle. This is aortic valve. This is right ventricle, and this is why you see there's also effusion. And the effusion is not a big issue here. The big issue is here. When you look at the valve more closely, you can see something coming out, and this ventricular end of this towards the ventricular end, you can see not towards the aortical, something is actually coming out through the valve. So this is like whenever you actually assess any kind of aortic valve, you need to look at first if anything is like, does it something look like any kind of masses, if any kind of like tumors or like any vegetation or thrombi. So, and this was long axis view. The same patient, when you do this short axis view, you can see that in short axis view, you do not expect to see something coming in the middle. You will see the valve cups, if it is bicuspid or it is a tricuspid, but you do not expect to see something in the middle. So, and this is like because of the thrombi, and you see then that the color, when we put color flow, and if you see the eccentric jet is actually the valve has perforated in the posterior leaflet. So, and this is somebody with acute aortic regurgitation, and actually is a infective endocarditis. So we actually referred the patient to the surgeon. Whenever you actually assess any aortic valve, you need to address a few things. So, and you need to look at that weight, LVOT diameter I mentioned, inner edge to inner edge method. You do in long axis view, zoom area for seeing optimal Veena contractor when you actually see to zoom that. So this is simple and rapid. And with this view, you can actually type 1, 2, 3 screening for rapid qualitative assessment. But for making final decision for mechanism type 1, 2, or 3, you need to assess with transesophageal echo. So the problem with it may overestimate central AR jet, underestimate eccentric jet affected by the size of the LVOT. So now jet area or LVOT area. So this is short axis view zoom view measure, and within 1 centimeter of Veena contractor, estimate advantages, estimate regurgitation orifice area. And it may overestimate or underestimate of direction of and shape of the jet. So, and PISA, this is not very easy things to do PISA. The problem with PISA, you can do rapid qualitative assessment. The problem, you cannot apply PISA method. It's a multiple jets and is a constrained jet and not non-hemispheric shape of valve. So, Veena contractor, it is quite, I showed you then in Veena contractor. The advantages you need to do in parasternal long axis view, you zoom this view, narrow the area of jet, or just apical to the valve. Then imagining plane is different from PISA. This is useful for eccentric jet assessment. So this is a rapid quantitative assessment. This is a surrogate for regurgitation orifice or independent of flow rate or during pressure. So good at identifying mild or severe aortic regurgitation. Problem with this, difficulty in assessment in the AR in the presence of multiple jet. Not good for bicuspid aortic valve and aortic regurgitation. So all methods, whatever we think about, all methods have some advantages and disadvantages. It depends, so that you see a single jet, or if you see multiple jet, you need to think about which method is good for. That you can see the pressure half. Also continuous wave Doppler align. Simple mild, incomplete jet is compatible with mild air and density. So it's may overlap between moderate and severe AR. And like pulse wave, that's why you need to think about when you do aligning properly with that. If Doppler angle is more than 20 decibels, you will not get correct information if angle is more than 20. And this is pulse of Doppler. So what you can see, this is simple supportive and signs of severe aortic regurgitation. And like if you see flow reversal in proximal descending aorta, it needs huge practice. So this is the advantage of that. It is more specific if flow reversing in abdominal aorta. So all these methods have got pitfalls, depends on the compliance of the aorta, less reliable, like in the pulse wave in older patient, and brief velocity reversal is normal. So that flow reversal in proximal descending aorta, you need to think about if the patient has got AV fistula in the upper extremity or rupture sinus or valsalva. So whenever actually you apply any method for measuring valve, aortic valve, you need to think about like it is any factor is actually compromising the quality. I mentioned is pressure half time. And what is the advantage of pressure half time? It is simple supportive signs of severe regurgitation. It is more specific in the abdominal aorta. So, and depends like pressure half time on compliance of the aorta, less reliable on older patients. So, and you do not rely on if you're assessing somebody who's 70 years old, and you shouldn't rely more on the pressure half time. You need to actually apply on other methods. So whatever actually then other main things I mentioned at the quantitative Doppler, regurgitation orifice area, regurgitation blow volume. So for volume, 3D is better, and best if you measure volume with CMR before surgery. So advantage is rapid quantitative assessment of the patient severity and volume overload. And it is problem with if you apply this method to it's a calcified aortic valve. So all this method has advantage. Also at the same time they have patient. So this is so far sum up. I bring my presentation. I think and assessing while you're actually assessing aortic regurgitation, applying echo. So it is actually, it's not very easy, but when you actually assess aortic valve echo, so if you understand a routine like physics of ultrasound and actually focusing on the angle when you actually align with the jet flow, that is crucial. And also you need to think about the causes of aortic valve mechanism. Cause, is it problem with the primary valve or is this problem with ascending aorta? Is it that if you are you planning to, you are doing a echo on a young patient, you need to think about, do I need to do mechanism of AR? Is the surgeon it might help surgeon to whether they can do like a valve for aortic replacement, repair rather than replacement. And thank you very much for your time. And I'm happy to take your answer, any questions, and feel free to answer back anything if you need.
Sir, thank you very much for this wonderful clinical presentation. Shall we move to some questions, sir?
Yeah, sure.
Okay. So the first question I have is from Dr. Rakesh Bachlu. He's asking, what is the difference between moderate to severely AR and moderately severe AR?
Okay, moderate to severe, that's a very good question. Moderate to severe AR, then if we go back to slide, it actually, this is a quantitative assessment. So I'm going back to a few slides. So what is the difference between, so when you actually make comment is whether it's the aortic regurgitation is moderate or moderate to severe. So, and you need to look at a few parameters before making it moderate or moderate to severe. Moderate, when you say very confidently, like for instance, if you have a Veena contractor width, so you can very confidently, if it is more than 6, you can. If it is the gray area in between 3 to 6 millimeter, then you see moderate to severe. And especially if you do with pressure half time. So pressure half time, sometimes between 250 to 500 is FD, LV, sometimes is LV compensate. So sometimes when you see between 250 to 500, and then if the LV is compensated because of the volume overload for long, like this one. So sometimes, and you actually is a bit confused about what is a moderate or is a severe. So moderate is severe, you have got a big question mark. Should I call it severe valve, severe aortic regurgitation, or still I have got a bit confusion about is a moderate, is it in between 200 and 250 to 500, or still it is a bit compensated. How we actually quantify moderate to severe. Did I answer this question?
Yeah, thank you, sir. So we will move to another question, is asked by Dr. Ziokov Joshi.
Yeah.
Is asking, what is your indication of AVR in AR?
Okay, that's a very good question. I'm going back to my one of the slides very beginning.
So shall we move to another question, sir?
No. I'm answering as is actually indication for aortic valve replacement. So that's the reason I put this slide at the very beginning.
Okay, fine.
So if you read that, you will find that in the European Society of Cardiology and journal. So management of aortic regurgitation. So you actually, surgery means like there are two things. You need to replace valve or repair valve, aortic valve replacement. AVR means aortic, you are replacing aortic valve. So when you actually repair, like if you have surgeons, you have got a young patient and surgeon has got skill, so you try to save, preserve valve without replacing. This is like you need to know about the mechanism of AR I showed during my presentation. But when it comes to the aortic valve replacement indication, so you need to look at few things. One, you need to look up the ascending aorta if its diameter is more than 5 centimeter, and it is class 1 indication. You need to replace this valve, aortic valve, refer to surgeon for replacing aortic valve. But if you've got a patient of aortic root is fine, then now it's a problem with valve itself. Whether patient has got symptomatic symptom, patient with aortic regurgitation, long extending symptom, they are coping well, but you actually miss this kind of patient. So if this patient is symptomatic, you need to refer patient for like valve replacement. And also I mentioned that white pulse pressure. If somebody's systolic 130 and you've got diastolic of 30 millimeter of marker, you need to think about is a severe aortic regurg. So you need to do proper assessment. You need to look at that subclinical LV dysfunction. These are the few points. LV ejection fraction is less than 50%. LV end diastolic diameter is more than 70 millimeter, and systolic diameter is 50 millimeter, or body surface area is more than that. So these are the indication for replacing aortic valve replacement. Did I answer back this gentleman's questions, please? Can we move to next one, please?
Yeah, we can move to next one, sir. So the next question is asked by Dr. Aarins. Is
Yeah.
asking, how does commissural AR jet look like, and at what view?
Okay, you need to actually commissioner AR duplex, like you need to sometimes look like eccentric. Look like eccentric. So you actually need to commissioner. It's very, very challenging to actually assess that jet is the commissioner somebody with like aortic, but the problem with the commissioner is sometimes it look like you need to do parasternal long axis view, and you need to also apply the Veena contractor on our other quantitative methods for assessing.
Okay, thank you, sir. Yeah, thank you, sir. Shall we move to next question, sir?
Yes, please.
Yeah, so the next question is asked by Dr. Vikas Reddy. He's asking difference between leading edge and trailing edge.
Fantastic. Leading, what we do, I'm going to my slide. So leading edge and like leading edge and internal edge. So leading, if you look at this picture, so what they are doing actually, this is the cavity of the ascending aorta. So it is actually not actually measuring not only the cavity, it's going outside. So this is leading edge. Now what is in like internal edge, you actually not going to outside the area. So this is that's why like when you measure these with the CMR, like in CMR they do not apply leading edge to leading edge. It's actually going out of the cavity. So this is leading edge. So still, if you see the guidelines, still in the European Society of Echo guideline published in 2017, you see a measure about in leading edge to leading edge methods. But when they mention same guideline, when they mention about when you actually validate with other data like CMR and like CT, then they didn't mention about leading edge. They mentioned inner edge to inner edge. Did I answer back to the gentleman's question? Hello?
Yes, sir. Yes, sir.
Yeah.
I think
So
it is. Yeah. So we'll move to the next one. The next one is asked by Dr. Aarins.
Okay.
He's asking, what does it mean by leading edge to leading edge?
Okay, this is the same question. So
Yeah, almost
leading
same
edge to
question. Yeah.
it's the same question. Yeah. So leading, I'm actually answering back her question. So leading edge is you do not actually measure only the internal cavity. It's going out of the internal cavity. That's leading edge. And what is internal edge to internal edge is actually actually. So this is inside, actually measuring inside. So this is when you actually comparing data with like CMR or CT. So they actually measure inner edge to inner edge, not leading edge to leading edge.
Okay, thank you,
Okay.
sir. So the next question is again by Dr. Ahrens.
Yeah.
How to measure jet area?
How to measure jet area. So
Yeah.
you need to actually apply methods. So you need to do a proper PISA method, and this is not very easy. I could do in another talk that's what how to measure this. It needs a huge time. So that needs to be understand about the physics of ultrasound, lots of things. It's not very easy. It's not very easy, to be honest with you. I didn't put any slide here so I can show that. But that's a very good question.
Okay. Thank you, sir. So next question is from Dr. Santosh. He's asking how to measure EROA by
Yeah.
PISA.
So that is again, I think probably if you arrange some kind of talks like about how to assess PISA, this is a very complicated process. And if I have got a slide, I can show that. So I've got just one slide, probably one slide here. Here. So what you need to do. So actually, once you put once you do the look at the jet flow, then you need to freeze your image, then you need to hemisphere that, and then you need to look at the regurgitating orifice, then you need to see the flow. And this is the very basic concept of measuring PISA, but I need to more details slides. And because this is one of a very complicated area, I'll be happy to share my slides if you need any further talks, or he can email me. I can send him some good slide where he can learn more about the PISA method. I'll be happy to email him back like about the PISA method. So this is a very complicated process. You need to freeze image, then you need to assess that hemisphere of these things. Then you actually measure PISA. Thank you.
Thank you, sir. Another question is asked by Dr. Joseph, and almost same question is asked by
Yeah,
Dr. Ahrens also.
yeah.
So, how do you measure Veena contracta without making a mistake?
This is a without making a mistake. So this is a challenging when you actually contract being a contractor. So you need to see the aliasing point, then you need to froze, you need to do measure it in pedestrian long axis view, and you need to zoom it. Then you need to, if you do not zoom it, then you might make.
Okay, thank you, sir. Shall we move to the next question, sir?
Yes, please.
Next one is, can you show again the chart of normal value of aorta?
Not not very in that. So are you talking about this slide? Okay. So for aorta, if it is a like anything aortic measurements is more than 4, this is dilated aorta. Like if aortic dimension is more than 4 centimeter, that is dilated aorta. So you need to think about sending this patient. Surgeons if the aortic diameter is more than 5.
Okay, thank you, sir. The next question is by Dr. Vidya. How to interpret abdominal aorta severity of AR?
Going to that slide. When actually you okay. Is she talking about this holodiastolic reversal abdominal? So you need to apply actually two methods. So actually, it is not from one view. So you need to assess valve that view, subcostal window, and also you need to actually see both, like descending aorta, and then actually this suprasternal window, and this is very challenging to do that. Suprasternal window, you actually can see both that ascending aorta and both descending aorta. This is the best way of looking into, but it needs huge practice. Did you get my answer?
Yeah, I think this answers the question. So actually, sir, there are a lot of questions coming.
Yeah.
Do you want to move? Can we take few more questions, or
Uh,
shall we?
yeah,
Or
no, we can, what we could do, like, if some
yeah,
questions, if we cannot answer everyone until 8 this morning, so what you could do, if you
yeah,
can email me all this question, or you can see that everybody can actually see my email, and then you can like actually email me. I'll be happy to answer all these questions back. I think give me a week time to get back to all these answers if somebody cannot, someone I couldn't answer today. So this is m.showkat@imperial.ac.uk. All unanswered questions I'll be happy to answer back. But
okay,
still we can take questions.
okay. So so shall we continue with
Yeah,
a few
sure,
more
sure.
questions, or
Yeah, sure.
okay,
Sure, go on.
okay, okay.
Until
So
8.
yeah, so I'm just taking some questions. How to differentiate primary and secondary aortic valve disease?
That's a very good question, actually. Primary and secondary aortic valve disease. And primary aortic valve disease, if I go to slide, primary aortic valve were problem with the valve itself. This is called primary aortic valve. And secondary aortic valve disease is when aortic valve, there is no problem is the valve itself, problem in the aorta. So this is called secondary aortic valve. So if you can see that, okay. So primary aortic valve disease, the valve is affected by the disease. So valve is making heart sick, not aorta. These are the few things. So when you actually look at the assessing valve, then you need to measure, look at the valve as morphology and all these things. But you do not only assessing valve, you at the same time also measure the aortic dimension. So you need to rule out, is the bicuspid aortic valve and is the primary valve, it is an acute cause like infective endocarditis or degenerative. These are the valve is making heart sick. And then secondary one, when the valve is fine, the problem was somewhere else. Like in hypertension, this is one of the commonest cause of secondary aortic regurgitation. Valve is just fine because is actually for long extending process is actually making the AC they become dilated, so valve cannot go up properly. So you get aortic regurgitation. So in secondary aortic regurgitation, valve is fine, but problem with ascending aorta. So whenever you actually assess aorta, you do not only look at valve cells, you need to look at the aorta. You need to have a comprehensive picture of valve and aorta. So if you just only look at valve, then you actually may miss some important diagnosis. Did she got my answer or he got my answer?
Yeah, thank you, sir. Another question is from Dr. Erins again. How to differentiate eccentric jet versus commissural jet?
Okay. And you actually, a commissural jet and an eccentric jet, actually it hits posterior valve of the aortic valve jet, eccentric jet. But for the commissural, it not necessary, but eccentric jet. mostly hit in the posterior wall. If it is, or it can hit only wall, or it can hit anterior wall. It depends on what the pathology is. That if it depends on, like, if it is in commissural jet, you will not that kind of characteristics.
Okay, thank you, sir. Another question is from Dr. Sridhar. How to identify true and false lumen in dissection?
Okay, so this is actually a very, very good question. So true and false lumen, you actually like with 2D echo, you need to look at very carefully. You need to look at where is the fluff is coming from. You need to look very carefully when you have to actually see that with the 2D is not sometimes it's not enough. You need to look at probably thinking about going transesophageal echo, then can actually help you to visualize pulse better.
Okay, thank you, sir. Another question is by Dr. Ruchir. He's asking any echo role in assessment of TAVI?
Any equitable assessment of TAVI? Yes,
Yeah.
definitely. It's a very good question. So like anybody is like going for TAVI, there are a few things we need to do. TAVI is the treatment for severe aortic stenosis patient. So what happened in TAVI? This is becoming more and more popular way of dealing with severe aortic stenosis, to replace valve percutaneous rather than surgically. So, and valve assessment actually starts, like aortic valve started from TAVI. For TAVI is actually not only for TAVI. You start looking into valve for aortic valve by doing echo, normal 2D echo, you start assessing that. But when you actually plan, the cardiologist decided to do TAVI, and then you need to do transesophageal echo, okay? It is not enough. At our center is one of the top centers in the world for doing TAVI. So in addition to do like assessing echocardiography, you need to all patients, those who are like CT scan to have the better assessment. So TAVI still has the big role. Echo still has a very good role. And actually echocardiography start assessing valve, then, and then what you see, then just before doing the TAVI, all patients go for CT scan. But it's still, a transesophageal echo is very useful.
Okay, thank you, sir. Sir, can we move to another question?
Yes, please.
Another question is in bioprosthetic aortic valve, post AVR echo study reveals
Yeah.
turbulence.
Yeah.
What is it due to, or its significance?
Maybe it depends on, also it depends on its problem is valve, and also it also depends on surgeon's skills. Sometimes valve, if it's a very skilled surgeon, they can deal this very well. But this is actually, you need to find out, look at the echo. When you echo this patient, you need to find out what is the problem. So a good surgeon, there shouldn't be problem.
Okay, thank you, sir. Next question is from Dr. Sridhar. This is how to differentiate thrombus, tumor, and vegetation.
That's a very good question. Very, very good question. That, whenever we see any thrombus, vegetations, and tumor. So if it is like tumor is like, say for instance, it's tumor, a heart tumor, like it's like benign tumor. Myxoma is the commonest one. Myxoma is not originating from, it's not a muscle, it's mesenchymal tumor. So obviously you will not see that blood vessels like blood sulfur not be huge. And echo, and also if it is a benign tumor, then it actually attached with the interatrial septum. So, and this is one thing. Same thing, if it is a tumor, malignant tumor, malignant tumor is highly vascular. and the vascularity is actually like, if you do like 2D echo, you cannot get conclusive information about diagnosing a malignant tumor. So you need to think forward and look forward. Like you might need to do CMR is actually better way of doing this, malignant tumor better than echo. And if it is thrombus, thrombus is a collection of blood. It doesn't have any blood supply, obviously, because it doesn't have good blood supply. So you not see good image. And especially if you do contrast echo, and if you do not have access to CMR facilities, contrast echo can guide you, help you a lot. So in contrast echo, because thrombus, you will not see thrombus very well in contrast echo, and tumor you can see easily visible. So this is how we actually differentiate. Did you get my answer?
Thank you. Yeah, thank you, sir. Sir, next question is asked by Dr. Anil. This
Yeah.
is asking AR2 access in catheterization lab in LAO view compared to which position and view during echo T or 3D echo?
Sorry, can you repeat the question, please?
AR2 access, uh,
Yeah.
capital AR2 access
Yeah.
in catheterization lab in
Yeah.
LAO view compared
Hmm.
to which position and view during echo T or 3D echo?
I didn't. I actually. Can you email me the question? So
I will mail
yeah, yeah,
these
yeah.
questions, sir, because there are
Good.
a lot of questions coming
Yeah.
still. Okay,
Yeah, I'll be
so
happy to. I'll be happy to answer back all these
yeah.
questions.
So I think it will be
And also
better
the
to
person
yeah
emails you, that give me also contact email, so I can, like, sometimes question is not clear, I can ask and that question
yeah
to
yeah.
better understand.
So okay, can you repeat your mail ID once more, sir? I will share with everyone. Hello.
Hello, I'm just going to my slide, so showing my email.
Yeah, please share your email ID so everybody can send you the questions.
Yeah.
So what
What
we
you
can
need to,
also do is, Dr. Shaukat, I will share the chat history with you.
yeah, sure.
And if any participant still has a question, they can leave their
Oh, sure.
question
I'll be.
along with the email ID.
Yeah,
And
yeah. I'll love to reply back everyone.
perfect.
You know,
That's very kind of you.
just one thing. One thing you need to consider, like from tomorrow actually, and like I'm a whole week I'm working like it. So I'll get back everyone by next weekend.
That's very generous of you, sir. But I think it was a wonderful session. There are a ton of compliments. Any last comments you have, and then we'll close.
And I do not know whether it helped the participants, but what I did, I tried my best to make it simple. And I'm actually thanking yourself and the team from Philips and the gentleman from Bangladesh, Mr. Kundo, to invite me and organize all these things. I know in technology, this is sometimes like, it make your heart beat faster, which I had at the very, 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 very beginning of the talk. But hope I tried my best to give some information, then they can take back to their work and practice, especially assessing the diameter and all these stuff. Thank you.